Alaska is placed within the United States as having the highest healthcare costs. And so we're highly incentivized to try to lower our costs. One of the ways that we're looking at doing that is doing a lot of telemedicine and innovation and really trying, in that way, we often, even though we're kind of on the, the edge, we have a large geographic area, a small population, we still tend to kind of be innovative in ways that other communities aren't, just because we simply have to be resourceful. So what we'd like to do is better understand what kind of connections we'd like to have in Alaska, and then as part of my role in Health Ties, I like to provide introductions and make that happen. So,
well, that would be great. I mean, we're in the process of putting together a number of pilot programs. So we spun out of the University of Oxford at the back end of 2016, so early 2017. And we did our first clinical trial in 2018, which we published in the Lancet in July 2018. And this time last year, I think there were probably 5 of us, and now there are 30 of us. So we've grown very rapidly in that time period. And we now have programs going on. We have a large program about to start in Hong Kong with a Chinese population there. We have a couple of programs in the US, one in Wisconsin, another about to start in Colorado. And actually, Colorado one is in 3 different populations. We have a number of different population groups which we're treating in the UK through the NHS as well, both in sort of primary care, depression and anxiety, but also in secondary care, quite severe psychosis, for example, schizophrenia. So at this stage, what we're looking to do is prove out the clinical model in different environments and help develop the commercial model with partners such as yourselves. And the idea being that we can take this to a sort of, as we develop our programs and as we learn about the user experience on those programs, we can fine tune them and not only make the programs most appropriate for the clinical purposes, but also get our pricing model right so it works with payers. And so we need partners to help us through that process. We're not just going to make it up and hope we get it right. We're working closely with partners to get there. So I guess that's the ask from you, is if we can work in any way with you, and then that would be a very effective way for us to try what is probably a more challenging population we'll find in other places because of the geographical spread. But actually that gives us some, I think, really helpful lessons for other populations as well.
Oh, fantastic. That's wonderful. And we have some of those people actually on the call, those key connections, so I'd be happy to do that for you. Well, that's a great introduction. And now if you'd like to go ahead and launch into what you were going to tell us, I'd love to have you do that.
Okay, so I'm going to share a screen first. Hopefully you can see that.
We can.
That's the River Tay, by the way, in Scotland. That's a place I lived for many years. And so I'm going to, can you see that screen now?
We can.
Okay, great. So, I started right at the wrong end of it. I'd already run through this slide deck, so there we go. So let's start off. As I mentioned, we spun out from the university sort of 2.5, nearly 3 years ago now. But the company is actually based on the work of Professor Daniel Freeman, who initially at King's College London and latterly at Oxford has been using virtual reality in mental health treatment research for 18 years now. So if you look for the literature in VR and mental health, Daniel's probably the most published. He's the sort of the seminal contributor towards this field. And I'm just going to, let's try this video. If it doesn't work, I'll stop it, but let me know if this is working. And this is Daniel speaking about what's so special about this approach.
The wonderful therapeutic mechanism underlying VR for mental health conditions is that because the person knows the simulations aren't real, they can try things differently in the situations that trouble them. But the learning they make in VR transfers to the real world. The key innovation of the work of Oxford VR is the automation of psychological therapy in VR by using a virtual coach. By automating therapy, we can ensure millions of people get access to the very best psychological treatment.
Okay, did everyone hear that? Did that make sense?
I think we got the general gist. It was a little hard to hear.
Okay, I'm sorry. Anyway, the basic point Daniel was making there was that you can actually get people to challenge their real world fears in a virtual environment, which gives them the confidence, because they know it's not real. They're prepared to take those things head on. And the thing that he's discovered in his years of research is that these learnings transfer into the real world really effectively, and that's been the sort of the basis for our clinical work. So I'll just talk you through what we're doing very briefly. So we're building a number of treatments, and the goal for us is to make them faster and more effective than traditional treatments. Significantly lower costs, so there's no need for a therapist to deliver these treatments. The therapist is actually delivered by a virtual coach, which Daniel also spoke about there. And the critical thing is that the experience for the user should be much better than traditional methods, which are quite challenging. And we're focusing on a number of areas, but particularly psychosis. We have a large trial going on in the UK in psychosis, and we're particularly focusing on anxiety disorders and depression disorders as well. And really the basis for this is the Beck cognitive model, which I'm sure people who know about mental health will be familiar with, which is really that our response to a situation is really nothing to do with the situation. It's more to do with the automatic thoughts that the intrusive thoughts that make us fearful of that situation. And really what that means for most people in practical terms in real life is that they get stressed, things happen in their lives that lower their mood. That combination of stress, worry, low mood leads to these intrusive thoughts really taking over, preventing them from doing things. So they withdraw and avoid situations in the real world. And of course, as soon as you start doing that, you end up in this vicious cycle where that withdrawal makes your mood reduce even further and your worry increase. And you end up really not going out, not doing very much, avoiding very practical things. And of course, that at a mild level is where a lot of people are a lot of the time. But when it becomes clinical, it actually prevents you from functioning effectively in society. And the goal of what we're doing is to really reverse that, to reverse and repair that cycle. So to give positive experiences within VR, which allow the user to challenge their intrusive thoughts, which in turn allows them to reduce their worry and improve their mood, to try things out in the real world, get positive experience again, and you end up in this virtuous cycle, getting back into real world activity. And so typically these treatments are delivered using a number of different methods, and you'll be familiar with some of the telemedicine techniques and some of the computerized CBT approaches, I'm sure, given the remote nature of your population. But essentially all of these solutions, whether they're face-to-face therapy, online telemedicine, group psychoeducation, or online guided self-help, all of them rely on the user to do their real world practice outside therapy, which is very challenging for them to do. And that homework is fundamentally important to getting good outcomes, and it's very, very challenging for the patient to do that. So bring that real world in. So we talk about taking the risk that bothers you without actually taking any risk. So you see here this sort of rather cartoony picture. This person here is in VR, and the real world they're in, it feels so real. It's an incredibly immersive experience, really draws out those intrusive thoughts. But on the other hand, they know that this isn't real. They know they're standing on a concrete floor in a clinic, and they can take the headset off at any time to escape that challenging world. So what we're doing is mimicking those challenging environments, triggering the responses. And then the critical thing is that the user can then can challenge those responses. And the key element of this is this person here, Nick. Now, Nick is our virtual avatar coach. She gives you various psychoeducation tips at the beginning of therapy. But as you're going through these experiences and going through these challenging tasks, she not only guides you in the activities, but she challenges you to question your intrusive thoughts as you're going through. And what's particularly impressive about Nick, human therapists, one of the great challenges with human therapists is there are some very good therapists and there are some not so good therapists. And the thing that makes a good therapist so good is that they adhere to the protocols and they stick to what is often quite repetitive and tedious activity with a patient. Now, Nick being an avatar, never finds that boring. She never deviates from the protocol. So she gives a very highly standardized evidence-based treatment approach. And of course, because she doesn't cost anything, she's part of the software, we can reduce the cost significantly as well. But also, critically, I think more importantly than anything else, is reduce the reliance on what are very scarce and very expensive therapist resources. So I'll finish here, and there are some videos, but I won't show those because I think the sound won't come across to you well. But essentially, we ran a clinical trial last year, which we published in Lancet Psychiatry in July last year. And we chose a phobia, which was a slightly interesting choice because I think, our focus is, as I mentioned, on anxiety and depression disorders, but this was a very discrete group that we could demonstrate some incredibly effective results to. And we saw pretty much double the effect that you would expect to see from face-to-face therapy. And this was in very short treatment sessions. So on average, people were doing 6 to 8 sessions of 20 minutes, so very short amounts of time in clinic. And in fact, post trial, we invited some of the control group back in, and they, in fact, a number of them did treatments, intensive treatments, in as little as 2 hours of therapy. So they came into our office for 3 hours. They did 20 minutes on, 10 minutes off. So 6 sessions of 20 minutes over a 3-hour period. And some of these videos, which you can pick them up off our website. They're on our Vimeo site, so I'll let you look at those at your leisure. But you'll see phenomenal impacts. People who couldn't do things 3 hours ago are suddenly able to do them. And things that were quite debilitating to their everyday life through their avoidance. So that in a nutshell is Oxford VR. And the key for us now is we, as I mentioned, we have a number of treatments around social engagement. And those social engagement treatments are nuanced to deal with particular conditions. So particularly psychosis, we have a very large trial going on in the UK, but our work in the US is more around a kind of mixed depression, anxiety disorder group, and dealing with the key problem for people with depression and anxiety, which is avoiding social situations. So we have a program that takes them through a number of challenging environments, public environments, such as being in a street, catching a bus, going to their primary care practitioner to book an appointment, going into a bar, going into a shop, going into a cafe. So there's a whole series of exercises they do there just to get used to the idea of being around people and to challenge their intrusive thoughts. So the key intrusive thought is, these people are going to do bad things to me. And that's the fundamental thing with social avoidance. And so by promoting social engagement, we're getting people to understand that there is no threat. Bad things don't just happen like that. Actually, these are really normal situations and they're safe and you can be comfortable and you can lead your life effectively in that world. And using exactly the same techniques that I've just described. So that's really what I wanted to share, because I know you wanted to leave plenty of time for questions, so hopefully I've done that.
A wonderful presentation and very exciting research. I'm excited to hear about the shortened time that it takes to treat people, and that seems like something that's really valuable. I'd like to open it up because we do have about 15 minutes. Is there anybody online or who's with us today that would like to ask a question?
This is Kai. I've got a question for you.
Yeah.
So, notwithstanding that, I think that the technology is very interesting, and the efficacy is something worthwhile and exciting to see. I have an underlying question, though, that I'm curious about how you view this, because as I look at the area of mental health, I wonder about having people solving mental health or fears by interacting with technology versus getting better at interacting with people. And I just wonder how you balance out the use of technology and using that as a surrogate to improving interpersonal relationships and using those to not only solve a problem in the moment, but to develop longer term skills so that someone is able to deal with other problems in the future with people, as opposed to going back to needing technology to do it. So I don't mean to be critical at all of the technology. I'm actually very interested in it, but that's just kind of my underlying bias. And I'm just curious about how you view that.
So I think that's a really important point. And I agree with you, by the way. I think technology can take people to a position where they are ready to interact with other people in a way they perhaps weren't before. So for me, the key feature of any treatment package delivered using VR is that it has to come under the guidance of a clinical professional. So I don't see this as being something that you just send to somebody and they use in their home. I see it as being something that you are prescribed and as either as part or as all of your treatment package. And the key thing we're trying to achieve with social engagement is exactly that. The technology is overcoming those initial barriers, but ultimately the goal of that is to get the patient to then interact with real people in the real world. So if you go back to that sort of vicious cycle slide that I showed, and then the sort of way that we stall and then reverse that cycle, the first part is to use VR to break down the fear and the intrusive thoughts. But actually, as you go back around that circle, the next stage is to then practice those things in the real world. Now, the videos that I didn't show you at the end that you'll see, that you can see on our Vimeo site through our website, what they show is not people in VR. They show people before and after in real world situations. And a critical thing is, just like you would in face-to-face therapy, you still have to do the real world practice. It's just that by using the VR, the real world practice is much easier. You've overcome that significant barrier. So I don't see it as a replacement for real world practice. I see it as a way of overcoming a barrier that for many people is really insurmountable without the VR.
That's really helpful. Thank you.
I'm wondering if you are looking at using this for drug and alcohol treatment, if that's an area that your organization is looking at, or because I've heard of other VR that's potentially in that area.
Yeah. So there's a whole range of disorders, and I think I mean our strategy is really two-pronged. One is to run a series of fairly generic programs. So one of the things that you will find across substance abuse, gambling addiction, PTSD, depression, anxiety, even eating disorders, they all have a common thread, which is this issue of being uncomfortable with the world in which you find yourself. Now, that doesn't mean that you can treat that disorder by treating that symptom, but you can certainly go a long way towards being able to treat the disorder by overcoming that symptom. And so that's a kind of general piece of what we're doing. But there's also a more focused piece of work that we're doing in a number of different disorders around specifically treating depression, for example. So there's specific modules that we're developing for depression at the moment. We have in prototype some OCD modules that we've had some very good responses to. And PTSD is another area that we're looking at quite closely. Drug and alcohol is another one that we're a little bit further behind on, but we feel pretty strongly we can make good headway in. And I think the one we are most interested in probably is opioid addiction, just because of the scale of the challenge, particularly in the US. And actually in Europe, opioid addiction now as well. But I think more generally, addictions and substance abuse are yes, absolutely things that we feel we can tackle, because all of these things have at their heart an environmental trigger. And I think so what Daniel would say if he's here is that every mental health condition has, as the key trigger for it, the environment, the real world. If you weren't in the real world, you wouldn't have the condition. It's about your response to the real world. And therefore you can use VR to create those virtual worlds, to create a virtuous response to it. So as an example, if you take the social avoidance or the acrophobia, we're rigging the world so bad things don't happen. Because in the real world, bad things can happen. And that's one of the dangers about taking people out actually in vivo in the real world and trying things out, because bad things can happen to you. So, and you need to minimize those risks. We can ensure that doesn't happen. So in the acrophobia, if you walk off the edge, nothing happens, you don't fall. It's actually entirely safe. And similarly with something like gambling addiction, one of the big things with gambling addiction is a sense of control. And you have to break that sense of control to get people to actually really deal with the addiction. And there's a sense of escape, which is a similar thing with substance abuse. So what you really need to do is actually, in the case of gambling addiction, you need to break the sense of control by rigging the gambling games that they play. So actually they do lose, and probabilities they think they know, really just they do. It's very else that they don't know. And then in substance, it's more about managing the cravings that people have, the cravings for the escape, and actually manage to desensitize the person towards that desire to escape. So yes, they're all things that we think we can do. We're pretty confident we can do, but they of course require partners and research to get to that stage.
Okay, fascinating. So we are running short on time. Go ahead.
Oh,
Kim.
I have a quick question. So Alaska has some unique settings that people live in, and do you customize the virtual reality world to fit different cultures or settings, or is it a standard, like if you were going to do a trial in Alaska, would you create a world that mirrored Alaska, or is it a standardized approach at this point in time?
So it's both, really. So if you take our Hong Kong work, for example, we've actually changed the environments entirely. So the street scenes have different buildings, have different advertising hoardings. It's relatively easy. There are some things that are very complicated to do, and there are some things that are relatively easy to do. So for example, it's relatively easy to change the voice recording. It's relatively hard to change the motion capture, so the animation of the characters, because that's something we have to do in a motion capture studio. But you can actually change the face and the physical look of that character without doing a whole motion capture. So in Hong Kong, we've changed, what is a Scottish lady giving the therapy in our version with a kind of, very sort of European face. We've changed that to a much more Asian-looking person actually we've re-recorded in Cantonese and in English and in Mandarin to do our work in Hong Kong. So if the population justifies the cost, and the costs are never too high, there are things we can do to make it more appropriate. And I think it's important that it doesn't have to be exactly like the real world. It doesn't have to be photoreal, for example. In fact, there's an advantage for it being a little bit unreal, because that helps that sort of two-way thing that's going in your brain. You need to know it's not quite real, but it's got to feel familiar enough for it to trigger those responses, and that is important.
This is Nigel over here, Bunby, and I just want to say it's really fascinating to see the research. And I was actually back at King's doing my master's back in the mid-2000s, and actually I think I attended a Dr. Freeman's lecture on one of these pieces. We were working on one of the virtual reality islands in Second Life back then. And my question is kind of on the technical arm of this, because the challenges we were having back then, of course, was limited internet bandwidth, and then also the getting users to engage with the technology. There was a significant technology hurdle for them to overcome with control and so on and so forth. And I know I've had a chance to engage with VR ever since, but do you find that the technology hurdle really limits some of the progress you can make with patients versus, and then how's that coming along? And I want to put it in the context of something like rural Alaska, where, there might be limited internet bandwidth and so on and so forth. Are these live platforms, or are they pre-made simulations that run locally on boxes? I guess, and I don't have to technically geek out too much because we only have limited time, but
Yeah, they run on a box that's local, is basically it. So we can't use the standalone headsets yet. They're just not powerful enough. The graphics processing isn't sufficient for us. So you need a tethered headset with a computer, but it's a laptop that goes in a backpack. And we in Hong Kong, we're using peripatetic teams that are taking basically a backpack with all the gear from office to office. There's no internet connectivity required when you get there. You simply put the headset on and go. My experience of people, so I think technology can be difficult, mainly for some of the simple UX things like logging on, doing usernames, passwords, filling out questionnaires. They're the challenging things mainly for people. This is very, very simple. You put the headset on, the virtual coach, you meet the virtual coach in a room. She explains the controls to you, which are very simple. There's basically one button to press on each hand to move your hands. And she guides you through everything. And to respond, we started off with voice recognition, but we found that actually gave real UX problems because people don't always respond in the same way. They might say yes, they might say yup, they might say aha. And of course, this is challenging for voice recognition often. And voice recognition also required the internet for us to use that. So we stripped all that out. And now when you're asked questions, a series of yellow orbs appear in front of you, and you grab the orb to respond. So we tried to make it as simple as possible. And I'm sure there are still things for us to learn there, but I think that's a really key point, because to have something which is only for the very tech savvy isn't a very clever marketing technique for something in mental health, is my experience.
Wonderful. Now, if we were to make a connection and find a place to do a pilot, would you be open to considering that?
Of course, yeah, very much so. I think it'd be a fascinating population for us to work with.
Okay, fantastic. Well, we're about to end on time. It's been a wonderful introduction to you, and I hope that we can continue this relationship. What we found with HealthTie is that we're really trying to be the place for these types of conversations in Alaska, the place that is a bridge between both people who need these services and entrepreneurs and innovators like you who are providing them. So we'll continue this, and we'll keep making sure that we make the connection. So thank you very much for your time. I appreciate it.
Thank you very much indeed for the opportunity, and talk to you soon, I hope.
Yes, thank you. And everybody online, if you'd like to have an introduction to Barnaby, please let me know. I'd be happy to do that for you.